Good morning, everyone, and welcome to our September 11th, 2023 community conversation. I'm Robin Shapiro. I'm the board chair of HealthAdvocateX. And as people are filing in, I'd like to just establish this meeting as a safe space. And so what that means is every voice will be heard and respected. And we enter this space understanding that we have different lived experiences. And as such, we recognize the potential for unintentional harm. And we just wanted to reiterate that we're committed to healing should harm occur. And I also wanted to say that today I'm speaking to you from Oceanside, California, which is part of the unceded land of the Kumeyaay, Kumias, and Payomkawamish Lusweno people. And I would like to acknowledge the Kumeyaay, Kumias, and Payomkawish and Lusweno people and community and pay my respects to their past, present, and future elders, and encourage you to take a moment to pay your respects to the unceded land in which we are all living, working, and playing at the moment. So today we're going to be talking about resiliency, and as such, I also want to recognize that this is the 22nd anniversary of 9/11, and as I was walking, I'm in Oceanside, California, and so it's a big military town. And as I was walking down the street, there were a lot of remembrances to this very important day. And I'd like to just take one moment to remember that day and all the people who lost their lives and the people who have been fighting for freedom ever since. So just take a moment. And I think it's a good foundation for what we're going to be talking about today. We're very lucky to be joined by our very own HealthAdvocateX board member, Dr. Dale Reisner, who's the former medical director of OBGYN safety and quality at Swedish Health Services, who's now doing a lot of work with healthcare providers, and Dr. Brad Lichtenstein, who is the founder of The Breath Space. And you all also saw his very long bio about all the different types of modalities and healing modalities that he provides. We've been very fortunate to have him part of our community for a very long time. And the topic today is resiliency and how to care for yourself when you are caring for others. So before we get to that very important topic, we are going to hear from Dr. Dale Reisner, who's going to be talking about public health issues of the day. Dale?
Sure. And hello to everyone. It's good to see those of you who can see faces and the names of the others. I am going to deja vu you right back to COVID. That's the primary thing. I'll talk about only one other topic, but COVID's definitely on the rise. I suspect you know this. Most places that you go, people are popping up. Some people are the folks that managed to avoid it the last 3 years and finally are getting stung. And I think that as we've looked over the past 3 years, what we've seen is not necessarily a more virulent form of it other than when we had Delta in 21. But the Omicron is just increasingly infectious, and so it doesn't take much to pick it up. It speaks to the things I've talked about in the past of like I've never given up wearing a mask in a grocery store, and I might have been the only one in there with a mask or very few. If you haven't been doing it, go back to it, please. Target, any of those kinds of places, Costco, because it's just people are not respecting that 6 foot distance for sure. And if you can position your shopping cart so that you're 6 feet away, plus you have a mask on, you're probably in pretty safe space, particularly if you've got up-to-date vaccinations. So just a quick note of what we've seen, and this is from the CDC over the past week, so more like last week. Definitely COVID is increasing, just in general infections based on the wastewater determinations. And also, sadly, they've seen a 16% increase just in 1 week of hospitalizations due to COVID, and 10.5% increase in deaths from COVID. So, wow. Yeah, so it's real. And many, I personally lost a colleague who was 80 years old. I don't know whether he was boosted, and who had traveled to Europe and had some underlying immunocompromisation, who got sick with COVID, couple of days, 4th day admitted to the hospital, 3 days later dead. That occurred, I just heard about it, but it occurred in May. So it can get you if you're in any of those kind of categories. And what's interesting, and a little sad to me personally, is that the rate of fully boosted is 30 to 40% max. And most places around the country, it's under 25%. And you can look on the CDC website if you want to see different states. Washington and Oregon are some of the highest for boosted, but again, that means like 35%. And if you look at populations, specific populations, as we talk about all the time with equity, actually the Asian population, and Eastern Indian is incorporated in Asian, in case I haven't mentioned that before, is the highest, higher than Caucasian, and then everything else falls below Caucasian. So we're still in a situation where we see inequities for lots of reasons. Some of it's fear, some of it is, mistrust of the medicine itself. But that's the current status. So just a reminder, the vaccination doesn't 100% or come anywhere close to preventing infection. What it's aimed to do is prevent hospitalizations, and particularly intubations, ICU, and death, the severe stuff. The vaccination has been shown to some degree or another, and I think we don't have the final numbers on this, to decrease your risk of long COVID as well. What is recommended when you look at effectiveness of the vaccine, I'll just talk about that a little bit. Effectiveness, again, preventing intubation and death in a younger population, the initial monovalent vaccination, so the initial Pfizer and just based on the company, the company Moderna, right? Their effectiveness was 76% in preventing those two severe things up to 6 months, and then dropped to 56%, but that lasted up to 1 to 2 years. So that was the initial. Then when we got the first booster, the hospitalization was the target, and it was 62% effective for from 7 to 59 days, so quicker than we would have thought with the original vaccinations, where we were saying probably 2 to 3 weeks to get the initial effect. So the boosting takes effect a little bit sooner, but it drops after the first 2 months down to about 24%. That boost effect is pretty rapid and doesn't last as long. And then for immunocompromised adults, so that was with healthier adults, and actually that is the group that is 18 years old and greater. So it's a pretty broad range. If you're immunocompromised, its overall effectiveness is not as much, but its effectiveness against intensive care unit admission and death is sustained and is solid. So it's just something reassuring for yourself and for your clients to know that those boosters really do make a difference with the more severe disease. And then I did want to talk a little bit about testing. So I don't know if there's any questions about or anything you want to interject or ask about, Robin, before I mention testing.
The only thing that I'm kind of curious about is the long COVID, if what are the rates of long COVID, and do we know about that? Because that really, from the people that I have heard who are ongoing sick and have secondary illnesses based on long COVID, it just seems to be kind of pervasive from the people that I hear from.
Yeah, I thought about doing some of that update, but I think in order to do it justice, let me focus on long COVID next month.
Okay.
Because I do want to
down.
really hit on the vaccinations and the other vaccinations to be thinking about if you're not up to date. I know that Chris talked about most of this the last time we had a community conversations, but yeah, I'd like to collect a little more information. There's a bunch of information about etiology and what we think is what all the symptoms are coming from.
Great.
So I'll promise to do that next month. So the two things I want to say about testing is most of us, if we're testing with antigen home test kits. There are some PCR based test kits, but they're quite expensive and they're run differently. And so the majority of us are using those. They are really good in terms of their sensitivity to pick up when they're a positive. So we're not seeing false positives. We can see some false negatives. And so how you interpret your test results depends on whether you're symptomatic or not, and some other things. So I just wanted to highlight those things a little bit. So you would be truly negative if you have symptoms and you've had 2 negative antigen tests, and to be 100% sure, if you had a negative PCR. There's a lot, I'm hearing this in the community, a lot of overlap symptoms, of course, because lots of things are, runny nose, headache, brain fog, all go along with the flu and with, everything else. So, so if you are really symptomatic and you've had 2 negative antigen tests, and they need to be at least 48 hours apart. So I'm hearing people testing every day. That does not help you. It's wasting your test kit money. And so 48 hours apart, and you're symptomatic, that antigen test should actually pick that up. If it doesn't, and you're still symptomatic, you might go to your provider and get a PCR, and also if you're sick, get a test for some of the other things that can cause that. One of the things just to mention, if you do get the flu, there's Tamiflu that can really decrease, and especially for your older and your higher risk selves or patients or clients, Tamiflu can really dramatically decrease the symptomatic component of the flu, but you need to start taking it in within about 3 to 5 days of when you have your symptoms. So make sure also that your test kit, a lot of us are buying them in batches now just to have them handy, that it's not out of date. What's published on the box may not be correct, because as we've done more of this work, the FDA has updated the expiration dates. So
what does that mean? Because I have a whole bunch that are like just expired.
So take what you do is you type in expiration date, COVID test expiration date, and you'll get, I think it's CDC sponsored. You'll get a site, and you can run through the company that makes the test kit, and you can actually look at the number on the test kit, and it will tell you. And it's likely, if it was expired in July, that it may last actually till December of this year. So
that is really good advice.
Don't need to throw them away. Just double check it. And I did that. We had a bunch, and it was about 3 and sometimes more months that you got more out of the kit. So the test kits that are currently being produced and being sold, I think, are going to have closer. I've noticed they look like they've got a longer away expiration date.
Mm-hmm.
Yeah. Yeah, and then just remember that the PCR really is the gold standard if you're really confused and you're worried about either infecting somebody else or whether you are actually sick with COVID. The other thing, I think that's really what I was going to say about the test kit stuff. But if there's
is it the CDC website, or you just type in?
If you type it in, I think it's easier to actually Google it and type in COVID test kit expiration dates. You can get to it through the CDC site, but there's a lot more monkeying around. So I think I've done it both ways, and I think Google's just as easy, or any search engine probably just as easy. Yeah. But it's a huge list. So you just have to scroll down till you get the company that produced the kit, and then you can see the number that's on your test kit and see what the actual updated expiration is. So I do want to say that the new bivalent doses are actually supposed to be out this week, and some places may even have them today. So if you are someone in a category that would want a second booster, if you haven't been boosted, I strongly recommend that. If you have been boosted but are looking at a second booster, then we should start seeing it more readily available in our local pharmacies and so on. And if you're not sure and you want a booster, just call the place you would normally go and ask them if they have the up-to-date stuff. It's been looked at, and it should be good coverage for any of these new variants that have come out. The latest, there's a list of, 25 variants out there right now in the US. And the latest one should still, anything that's an Omicron variant should be.
And if you don't have any underlying symptoms, you've gotten all your boosters previously, should you get boosted?
You should not. If you've already had a booster, you don't necessarily need to, unless you are over 65. Some places are saying over 50. So that would be up to you in a discussion with your, with your doc, or if you're your healthcare advocate person. And for sure, if you're greater than 65 and immunosuppressed, I would strongly consider it, especially since we know immunosuppressed people don't get as big a response out of the virus, the vaccines anyway. And then at the same, whether you do it at the same time or not, please remember that RSV, which used to be really considered more of a complex virus for kids, was making older adults and immunocompromised adults quite ill, and some were not surviving that infection. So there are updated RSV vaccines, and the flu vaccine is thought to cover the variant of flu that we had last year. So probably will be more effective than the flu vaccine was last year. So be sure to get those. And if you are not up to date with your tetanus, which I'm not, found out, please do that. It's very easy to get exposed to tetanus just by, working in the garden, or, scratching yourself on some rusty
That's
nails.
every 10 years.
Yeah.
So we have two questions about the boosters. One is, is it the original, the original same formulation as the original bivalent? I'm assuming that it's tweaked.
Similar and tweaked. But it's very similar as that. And you can get either both Pfizer and Moderna have it. So you can switch companies. That's fine.
Doesn't matter.
Doesn't matter.
Okay. Right. And then if somebody doesn't remember if they got boosted, when was the last season for the boosters were available? Or is it, can you check it online? Or I don't know. I still have my little card, but
I have my little card too, but if you don't remember, if you were getting it at a pharmacy or a doctor's office, they should have a record of it. State of Washington keeps track of that stuff. I don't know if every other state is as good in those kinds of things, but yeah, I would check with your local pharmacy if that's where you, or your doctor's office, wherever you were getting your other.
But the last season for boosters was last fall.
No, the booster started in the fall and ran through the spring and summer, and there's still some of that booster around, but I would go for the updated, what they'll do is you give them your healthcare information and your age, and they will determine which is the correct booster for you, because that they really want to make sure that the updated booster gets to the most susceptible folks. And so if there's other booster around and you're not in that group and you haven't been boosted, they'll probably give you that one.
Gotcha.
Yeah.
Okay.
So just one thing about Paxlovid, I know there's a lot of discussion about Paxlovid, that it is meant to be for 65 and older or immunosuppressed people who get ill, have you've got symptoms, you've got a positive home test, and you ideally start it by 3 days, but 3 to 5 days, 5 days worth of medication you take twice a day. It will give you almost 100% of people I know who've taken it get this sort of metallic taste, weird taste in your mouth. There are contraindications if you have chronic kidney liver disease, HIV, and we're not using it in pregnancy unless somebody really has a bunch, way too many risk factors, and that would be a personal conversation with a high-risk OB doc. And the altered taste and some degree of diarrhea are the two most common symptoms that you get from taking the med. So the thing about the med that we hear about all the time is, and by the way, that if you have an immunosuppressed child who weighs at least 88 pounds, they have access to Paxlovid if the provider thinks it's appropriate. It is by prescription, and that's very good because there are a lot of meds now on the list that are contraindicated. And most of them are for chronic conditions, some antihypertensives, some things like that. So you or your provider can just look up Paxlovid, information. CDC has a really nice little one-pager for patients and families with facts, so you can go there for it. And then I just want to remind people, I've said this before, rebound COVID can occur with the wild virus and with Paxlovid. There was one fairly recent study looking at just 170 people, so that's not a lot.
Pretty small.
In that group of 170 people, rebound after the natural virus, no vaccine, was 7 to 9%. In the Paxlovid group, it was double that. So it does appear to happen more often. If you get rebound symptoms, you must retest. You're probably positive. And what many people are thinking is that it may be that we're just not using the Paxlovid long enough. And I'm sure we will see studies come out this next year looking to see if longer therapy avoids that rebound and makes it safer for people and so on. So we do have a few other questions, but we're going a little bit long, and I do want to get to Brad's comments now. So what I'd like to do is thank you so much, Dale. This was very thorough, and let's pick up the other comments and questions about COVID, etc., at the end, towards the end of the session today. Thank you so much for putting them in the chat. And I'd like to turn it over now to Dr. Brad to talk about resiliency.
And I just want to say thank you to Dale, because I could have kept listening to you. So I find that's information helps me sometimes feel as if I am resilient. So thank you, Robin. Hello, everyone. It's nice to see your names and faces and pictures as I'm looking at everyone. So today I was going to talk a little bit about resiliency, burnout, looking at the learning objectives. We were just talking about the symptoms of burnout and how to reframe perspectives, and the importance of understanding the parasympathetic and sympathetic. And I'll get to that in a moment. But I was going to say, raise your hand if you feel like you've had burnout, but I don't know if I want to ask that, because I'm imagining what I'm going to see. And the interesting thing, though, and actually that is a fascinating question. Maybe I could ask everybody, but because a lot of times people don't say they have burnout. And there's this whole debate in the APA, in the literature, about what is burnout. Do I have burnout, or is it just anxiety and depression? And I think that's really fascinating. I could get into another time. I'm not going to digress, Robin, about my challenges with the DSM. And there's a lot of those I can say. But regardless, I like the criteria we have. And I just wanted to mention, this is one model of criteria for burnout that I resonate with. And it's talking about the 3 domains, burnout syndromes, and just see if this fits for you. The first one they talk about is depersonalization. And let me back up. This isn't just about healthcare providers. This is healthcare providers, advocates, family members. So the term burnout actually began, I believe, in the 60s. I was reading that they were talking about people in the Haight-Ashbury and using certain drugs, but then it immediately got adopted for the medical community, for physicians who were treating people. And so that's one of the historical aspects of burnout, but we can apply this to anyone, especially caregivers. And if we're talking about the 3 domains of burnout and the syndromes here, the first is depersonalization. And what people experience is they feel more insensitive towards the very people that they are caring for. And I find that fascinating. And I have experienced that myself. Other people have. And one way that it shows up, I think, is when we start to talk to the people that we're caring for, and we start to get that impatient feeling of, well, did you try? Did you try? Well, we can say that that's in our attempt to help, and we want to be of service, but we start to become more insensitive to them. And it's like, oh, they're not doing this. And then what happens in the syndrome is you go from the depersonalization of the people that you're caring for ever since you started caring for them. And then it becomes emotional exhaustion. You feel less engaged or excited about the caregiving, the work itself. And so then it's like, oh, I got to go to work tomorrow. Once you're at work, you might feel more engaged, but it's getting past that hurdle of such fatigue. And then as a result of that emotional exhaustion, it spirals into the 3rd domain, which is that sense of low personal accomplishment, where you say, is this doing anything? I feel like I'm just putting Band-Aids on. And then, of course, we say, well, what's the point of it all? And that just leads to more depersonalization and the exhaustion, and it just spirals and spirals and spirals. This is different than depression and anxiety, because it's geared around the work that we're doing. And if you look at some of the main factors of burnout, and I've seen several different studies about this, but in all of them, what's fascinating is the actual care for the person, or the actual work. So if you're a physician, if you're a caregiver at home, if you're an advocate, the actual work accounts for very little of the burnout. The main factor that is the biggest component of burnout is lack of control over the work conditions. So if it's at home and you're caregiving for someone, you don't have any control over the situation or the environment. But think about what that also means. I have lack of control of getting people to the healthcare functions that they need, or the providers, or finding the caregivers that I need, or navigating all the paperwork and all of that. The lack of control is the major factor that causes burnout. And just hearing that, how can we not have burnout?
I'm making a note to myself also, because I think that applies to a lot of the work that we all do together. And I'm also recalling the the February 2023 session that we had on community conversations with Dr. Veronica Zantop about mental health and moral injury, especially in the medical field, which is different. And I don't know, Ashley, if you can put that in the chat for people to refer to, because I think that's part of the soup of burnout that we're thanks, Ashley, for putting that into the chat. I think that's important to reference as well.
I think it does, because the other three that they talk about are time pressures, which we all understand that.
Mhm.
You know, and I'm just thinking, as a physician, when we went from paper charts to electronic records, the time pressure changed. It was worse, as you know, and navigating those. Chaotic workplace is a third. And then the fourth is, and I think this fits with what you're talking about with moral injury, is lack of alignment of values between the caregiver. I'm trying to use that term broadly, the caregiver, the care provider, and institution, and the work, the management, all of that. And so I think that's where that moral injury comes in. I'm being asked to do this, and I want to do it to the standards of care or to my value and dedication, but there's nothing that in the system that's allowing me to do that. I think that's an aspect of that moral injury, and
Absolutely.
I think it all fits.
Yeah.
And I even think about my husband, who has been trying to navigate the insurance system for his parents, who don't understand the computer, who can't read the English very well, and he's reading it, and he went to Stanford, and he's like, I can't even understand this. It's like, so that's a concern. How can any of us do that?
Mm-hmm.
And so I think this is the aspects of burnout, and we're being asked a lot. But to address one of the other learning objectives, and this is my big, so I say to people, my soapbox. I think it's not just our work environment. I think the zeitgeist of our population is do more, your side hustle. I hear this with the people I work. You got to have your side hustle. You got to do this. And I want to remind people about the nervous system, just basic physiology. There's more than this, and I'm making it reduced. I'm simplifying it, but we have the sympathetic and the parasympathetic. We like to say the sympathetic is stress, and I don't want to use that term. We could talk about it as stress, but then that has a negative connotation. The sympathetic is about mobilizing to do tasks. Yeah, it helps us run from the tiger, but it helps us carry the groceries in or caregive for someone. We're doing some exercise. Exercise itself is sympathetic. But we also have the parasympathetic. And the parasympathetic is, as everyone has probably heard, the rest and digest. I'd like to spin the idea of being productive rather than say, oh, I got to do more to be productive. If you want to be productive, you also have to rest and digest. Our culture doesn't acknowledge that. We say, I'm not doing enough. And I think that is part of this burnout that we have to attest to. It's not coming, how much of it is not coming from other people, but our own selves. I can remember so many times I've come upstairs and I said, oh, I didn't do anything today. And someone would point out, you just worked for 3 hours. Oh, but that's this. And in a modern society, when we have people who are working, and I'm thinking about the people we're caregiving for and ourselves, it's like, if you're working and then you have to come home and you have to clean the house and you have to order dinner and you have to do, that's work too. That's sympathetic. What are we doing to support parasympathetic? And can we start to say, in order for me to care for others, I must take 8 hours. I talk about the 8-8-8 rule. I talk about 8 hours of active sympathetic, 8 hours of parasympathetic, which would be sleep, and then 8 hours of active rest. And that concept is so bizarre to people. Like, what's active?
I've never heard of that.
Well, I say active rest. Active rest is when you're knitting, when you're at the end of the day reading, when you're eating your meal, not at your computer. I shouldn't say anything.
You're making me laugh because that's, yeah.
Yeah. Eating at your computer or eating while watching, depends on if you're really resting there. I mean, we don't engage. I mean, there's a thing on Netflix right now, I think, about the blue zones. Yeah. And the one thing I don't like about that is we have gone in our Western mind, looked at these blue zones. Blue zones are these areas in the world where they have the longest life expectancy, they recover from cancer. And then what we do is say, oh, they eat mostly plant-based. All of them drink except one. They all exercise. None of them exercise. They don't think of it this way. They go for their walk, active rest. This is something you do. You have an hour-and-a-half meal because you're talking to your friends and you're enjoying your food. We've made it a prescription rather than made it a way of being. So when I talk about 8 hours of active rest, it's what are you doing to restore, to engage? And this gets into the treatments, like, if we American version, Western version, what do we do? It's like, well, what cultivates your sense of ease and peace? And when we see resiliency, one of the most important things is community. And when we are being told, work harder, you're not doing enough, we feel bad about ourselves. We start to feel emotional exhaustion, and we hide it from everyone, and we don't talk about it. And so we further that whole cycle again. And so active rest is about saying, how do I engage with myself? How do I engage with others in a way that I feel bolsters me up? And so that's
how do you fit it in when you're working and sleeping 8 hours and caring for kids and or elderly parents? And how do you like do that? Give us some good news, Brad.
Well, no, I think that's a great question. And part of it is also to identify the system. So one, when you're caring for everyone and you say, is the system support me? I mean, so to also know that if you can't do it all, you are not a failure. That is the first place I hear everyone go. I'd love to meet people who don't go there. So how do you fit it all in is one, to be very clear about your boundaries. I'm going to say a trite expression. You've all been on a plane, maybe. If traveling with a small child or someone who needs your help, put your mask on first. We do not put that rest, that 8 hours of active rest, at this highest part. I believe that if we could shift the narrative and say, yes, you have to take time for yourself or you will not be of any service to anyone else. And guess what? People are going to try to make you feel guilty. They will. You hear that. Work, all of that. So what can you do to remember that? Reach out to the people you're talking to here or on this conversation. Please do. But if you cannot think of it as a weakness, that's the first exercise. I just can't say that enough. The other part is, what do you like? What do you do? I mean, it took me years. It took me years to finally say, I just finished work. I'm not going to do more work. Now, I used to work 13 and 14-hour days up until like just a few years ago. So I'm not the model for that. I understand. And yet I still would take my time every morning to have my rituals. And I like to say it that way. What are your rituals, your routines? It's not a habit because it's sacred. I get up every morning, feed the cats. Sorry, they make me feed them. Feed the cats. Then I make my tea and do my meditation. Now, sometimes I only give myself 5 minutes, but what works for you? Now, what I love is I'm into knitting. But what works? And now I got my husband in it, which was really great because it gets him off the phone. The one thing I would say is check what you're using with social media, or not even social media, just your phone, your computer. Are your alarms on? Do you have an Apple Watch? Do you have a Fitbit? I discourage those. Because what's the compulsion that we develop there? So I would say anything that you can do to move, that you enjoy, and that you love is going to be the most important thing. I mean, we could talk about the specifics, journaling, meditation, but what are the things that you find that you don't apologize for? And how do you ritualize them? even from taking a shower. That would be the first.
There's a great comments from Vanessa at Bastyr Advisors that she's able to run through an active rest menu in all too rare moments. Yeah.
Yeah.
Yeah. Yeah.
I also brought my show and tell.
Oh, oh, nice. Oh my gosh. Look at that.
Wait, hold it
Gorgeous.
up again, Vanessa. Sorry, I just need to see it
Wow.
again. Oh, that is, oh, wow.
And it's
Amazing.
all finger crocheting, so I don't even have the excuse of I can't find my crochet hook. But I love that, Brad, because I like you rely on routines. I'll make this brief, Robin, to get back to Brad. So for me, it's actually I use the notes function in my iPhone, and I have the checklist mode. And so when I get up in the morning, I don't even have to think about it because my morning, I have 2 special needs kids, 2 dogs, my husband's super busy, I'm running a business. And so it's like, it feels impossible, but if I can just, we usually reach for our phones first thing in the morning. And so if I can make the phone a source of my checklist, then I don't even have to rely on, I don't know, like it's just not going to work if I don't have it already written down. And I forget and then remember to do things like, knitting. And I will say, I will add, Brad, you'll probably appreciate this as a fellow knitter, crocheter, crafter. This is a blanket for my best friend. It's actually in 2 colors that I do not like, but every time I look at the fuchsia and the pink together, I think of my best friend, Tiffany. And as I'm doing it, it's actually a meditation on her and our 40-year friendship. So
amazing.
Oh, that is fantastic. I love hearing that. I would say I appreciate that you're using the phone for good if you can. But one thing that and this is just with my patients, is telling them to keep their phone out of their bedroom. I know that's a hard thing for a lot of people. And I do recommend, especially if you're questioning what your schedule is, I recommend Cal Newport. Cal Newport wrote Deep Work, A World Without Email, Digital Minimalism. But he talks about keeping, it's hard for me to keep a physical calendar. But one of the things he does is write down every day what you're doing and how much you're blocking out. So you have one column that is the scheduled. So like this was an hour. I have patients around it. I know what's happening. But if I say after this, I'm going to do chart notes for an hour, you have a column right next to it and say, what did you really do? And what I find is I'll block out an hour for chart notes, but it takes me in 2 hours. And then I feel stressed. And then I feel anxious. It's like, I couldn't get it done. Well, I couldn't get it done. I'm blocking this out. So you get to look at your day and see what you're really doing. And I think that's a really helpful key. You could just look up Cal Newport time blocking calendar. You don't have to buy his calendar. But it's helped me so much to look at my schedule and say, what did I say I was going to do? What did I really do? And going to Vanessa, it's like, no, it's 6 o'clock. It is knitting time. Sorry.
Love that. And
6 a.m., let's be clear, 6 p.m.
Yeah.
Good time.
Patsy Stahl also had a great suggestion, which was intersperse active rest within the day. Laughing. Remember the laughing club. What's the laughing club? I don't know what that is, but I definitely want that.
Patsy, do you want to? I've done laughing clubs. They're very fun.
Really?
I think, Patsy, I think your mute might be on. We'd love to hear what you're saying, though.
You can only see my hands moving, huh? I think it was Harborview, Brad. But anyway, one of the emergency rooms in the Seattle area, the staff got together and they would take breaks when they were really stressed and go outside or into a area separate from the work emergency room, and they would intentionally laugh. And then one of them actually came to Tacoma and had a workshop on it. And you guys, that was the best experience I have ever had. And I don't know if it's still available, but what it reminded me of, and I was experiencing burnout as a teacher at that point, was my gosh, I'd forgotten to laugh.
Mhm.
Intensity on the job does not eliminate laughing with our patients, our students, or whomever, and a damn good belly laugh, you know? It totally changes the chemicals in our body. It's wonderful. And it made me more pleasant. And so I do that a lot now, and it really does help me get another perspective. And that's something you don't schedule, you know. And God, I hate scheduling as much as it's necessary, Brad. As a teacher, everything was scheduled, you know. The bells rang, and so to do things that we can intersperse that are not necessarily scheduled, while we also have our scheduled rest times, I think is it's almost a defiance against the burnout, if you know what I mean. It's anyway. So sorry.
In biofeedback, we talk about giving our patients the formal practice, the 20 minutes twice a day practice, but then we talk about the interruption practices. And
There
we
you
say
go.
throughout the day, what's 1 to 2, just 1 to 2 minutes. It's going to prevent the escalation. So even if it brings you back down here. But in one of my classes, when I taught at Bastyr, we would do this. We would say, we're going to stand in a circle and people would throw a laugh. So somebody would make a laugh and somebody would have to match it. Then they throw a different laugh, and it's fun. And then we say, no, I'm sorry, you didn't do that right. I went,
Yeah.
I've never heard of that. That's great.
Yeah, we did it at a Washington State Medical Association foundation dinner. So, you know, we're trying to get people to donate money. And we started with someone who has had some training in laughter therapy. And I thought, oh, this is ridiculous. Purposeful laugh like it's not spontaneous. How can this work? And pretty soon the whole room's belly laughing, like you said. So yeah, it doesn't, when you start it, it's going to feel really weird. But the other thing is, and I know, Brad, you said stay away from your equipment. But I have part of what saved me in the last, so I retired in November of last year. It's almost been a year, which is so crazy.
Wow.
And part of what saved me actually was I got an Apple Watch, and it pings me when I need to stand up. And I put in as many hours a day as I could have that ping. And when I stand up, I sort of automatically take a deep cleansing breath. And you know, it's that minute or two that breaks it up. Because you get immersed, and you're not going to not get your work done if you stand up or walk around the house or the office for 30 seconds or 60 seconds or something, just enough to get you to move and not be hunched over. So anything people can do with little reminders, I think.
I don't completely, do you like how I said that? I somewhat agree with you.
You don't have to agree with me.
No, I think that we want to use the tools people have to begin, but I do worry with the people I work, how they slide back into checking the emails. I mean, I remember the beginning of the COVID pandemic. How many times did I have to look in one day about the numbers? I had, I wanted to look, and I don't think uninformed is the way to be, but I also did not know how to regulate that. And so that's where they can become, it can become anxiety producing, where people they wait for their Apple Watch to tell them to stand. And I think you're probably outside some of the norms.
I'm outside the box in a lot of ways.
Yeah, use whatever you have. I mean, you can use your phone and set alarms randomly throughout the day. I think that's great. I just know I don't believe we can multitask. I think we shift focus with laser-like speed, which then activates the sympathetic nervous system. And then when we get pings, it activates that response. And then, so finding that time where we can, and if that's all you're using, the reason I forbade Apple Watches in my house, and I'm an Apple lover, is I just knew that my husband would get, there's a text, and he said, but I won't be on my phone. It's like, but you'll be looking at your wrist every few minutes. So I love technology. I do. And I also am concerned about how we use it. So it's always about the how for me.
Yeah.
How are we doing things? So The interruption practices are really important. And I have baked in my schedule that I have 5 minutes between people to always get up and stand around. And I have a standing seat at desk. But movement, I think, is really interesting. I think one of the downsides about exercise for most people, and I understand this because I was taunted and tormented when I was a kid in Pittsburgh, Pennsylvania, growing up, who didn't know how to throw a baseball or anything. Exercise has a negative connotation for many people, and it has to look a certain way. And that's where I go back to the blue zones. They don't exercise. The groups of people aren't going to gyms. They're moving. They're moving in a way. And what's so nice about out there, that's Lake Forest Park in Washington, is when your eyes start to scan nature, you're changing, going back to what Patsy said, your perspective. You start shifting to different things, and that affects your nervous system differently. And you see the different colors and shapes. So I'd say, as long as there's clean air, get outside, move, but don't confine yourself to needing to exercise. That's the negative language, I think, that we often share.
Interesting. Yeah, go ahead.
Go ahead.
I just wanted to, so we're at, we have about 9 more minutes, not very much more time. So I wanted to invite people, if you do have questions for Dr. Brad or Dr. Dale, to please put them in the chat. And also wanted to just invite you, Brad, are there any other final things to?
I did want to say something about gratitude. I do a lot of gratitude practice from my meditation background. That can backfire in many people who are caregivers. And it can backfire in that what I hear is people will say, oh, I'm so grateful for my health. Oh, look at all these other people. Oh, they have it worse than I do. And what they instantly do is negate their own needs for sleep, for rest, for movement, because other people have it worse than they do. And I want to just go back to everyone is different and everyone needs active rest. Or you just think about it. 3 days without sleep, you're going to go psychotic. You can't function. So what are we doing? How much are you saying, wait, I can be grateful for what I have without negating my needs? That's something I just wanted to mention. And I was on a conference call with one of the first people who studied gratitude, and it is different with different cultural backgrounds also. So it doesn't work for everyone. So I know when it can be used as shame. And I guess that's the word I could have said. We just don't want to spiral into shame. So that's one part I wanted to add, Robin.
That's great. And I think that's really important because we are a comparative society in the US for sure. And, there's always somebody who's excelling in something you aren't that good at it, like you're throwing a ball. I'm with you, Brad. Yeah. So, people need to figure out what's core to them that makes them relax and makes them, whether it's knitting or whether it's something else. And I think then the biggest thing is how do you bake that in a way that doesn't feel one more chore?
And how do we learn to say no? I think this is the other thing. I tell people that saying no, how do I say this? Saying no is a promise. You're saying that you're taking what they're saying seriously and agreeing you cannot fulfill their request. I'm taking what you're saying seriously, and I am agreeing I cannot fulfill your request. And you do not need to immediately say, because my sister's having it's like, I can't fulfill your request. I think in our culture we have, in motivational interviewing, it's a technique we use, and there's something called DARN talk: desire, ability, reason, and need. And I think caregivers, I'm making a generalization, have a lot of desire. I really care about you. I do care about you. And we can go through the reason. There's a good reason to do this, and there's a need to do this. But the ability is, oh, well, I've got 2 arms, 2 legs. I have the ability. And we forget that the ability is so multifaceted. Do I have enough sleep? Do I have enough energy? How many people am I caring for? Do I have enough time in my mind? I mean, and we just say, because I have the energy and the strong will, I should do it. And we're not thinking about all those. We can even get into socioeconomic, political factors as well. So ability gets conflated or deflated, depending on which way we're saying it. So don't just say, oh, I desire it, I should do it. Do I have the ability and the internal resources to do this? And then get comfortable saying no. I used to have saying no parties too. And I do this exercise.
Wow, what is that?
You want to come?
Should have gone.
It's about saying no without feeling the need to justify, because I'll
Yeah.
do these really manipulative things, like, oh, can you give me $5? Oh, it's so I could get a Uber to see my patient. My patient's dying. I'm the last person that can you give me $5? And just say no. And so many people are like, but I have it. Can you just say no? No, I can't say no. And then we flip it. And to hear no, it's like, oh, I'm rejected. You're not being rejected. Don't you want to see the person don't you want help from the person who's best able to help you? So there's a lot of, as you're saying, cultural rewiring we have to do here in this, pull yourself
Well,
up.
I think also, especially if you are in the community of advocacy, your whole basic desire is always to help if you can. Like, never say no. So that's the no party is, I'm very intrigued by that. I'm gonna have to follow up with you on that.
Yeah, and just to be transparent, I mean, I saw this with my mother, who died in 2021. And my sister, my mother and my sister both have, and my brother all have genetic disorder. And my sister was saying we should move my mom back to her house. It's like, you physically cannot do this. I was like, but she's not getting, I know. And it's, how do you find something I practice daily? How do you find acceptance and compassion and peace with this system is, you can bleep me here. This system is bleep. And I can't do anything about that. And it doesn't mean I don't care. And I hear people burn themselves out saying, but I just got to try everything. It's like, but that trying is not going to do anything. And so
that's great. Well, just as a final wrap up, I know we could talk a lot longer, and Brad, you're not going to plug this, but Brad does host a weekly meditation if you're interested at thebreathspace.com. I love it. I've been doing it since the pandemic. You're really good at it. And any final thoughts, Brad first, and then we'll end with Dale.
I would just say, all the compassion you want to have and kindness to everybody else, ask how much you're doing to yourself.
Good point. Thank you for that. Thank you. And Dale?
Well, I just want everyone to know I did pop in the link to the list of expired meds is actually run by the FDA, which makes sense. And so that link is in the chat.
Fantastic. Thank you so much. And I just wanted to let everybody know that we are working on getting a speaker who actually is going to be addressing artificial intelligence and healthcare, that we're close to confirming for next month. So watch for that. And we have a lot of gratitude both for you, Dale, as well as Dr. Brad, in joining us today and giving us, I thought all the suggestions were really, really helpful and specific. So thank you to both of you and everybody in the audience for sharing your experience as well. We hope to see you next month at HealthAdvocateX Community Conversations. And please put also on your calendar, we will be launching on October the 10th at 4:30 Pacific, our first X Center. It will focus on transgender health. And so if you'd like to know more about that, read your newsletter or contact us at info@healthadvocatex.org. Have a great Monday. Take care.
Thank you, everyone.
Thanks.